because of the multitude of manifestations associated with this post-COVID syndrome, likely the mechanisms are varied. Perhaps for a particular organ system, there is a particular mechanism which may not be applicable to another organ system. However, I would like to start off with my disclosures. I should mention that some of the companies that I consult for to make vaccines, antibody tests, and also antibody preparations for COVID. Okay, this is a picture I took out of Nature News, and the title is "The Lasting Misery of Coronavirus Long Haulers." And you can see this individual. He is a COVID survivor from Italy, and despite several months after testing negative, he still has a lot of respiratory issues, and he is undergoing respiratory therapy and training afterwards for improving his breathing. So this is one of the classic persistent manifestations of patients with COVID, and this is especially true for those who have had severe COVID. Here are some of the examples from a scientific reports article that I've systematically looked at multiple patients who have suffered COVID and then done CT scans in all these patients. And you can see the varied manifestations that have been reported, starting off with interstitial pattern, interstitial fibrosis. You can have ground glass opacities, pleural thickening. You can also have, again, extensive ground glass opacities, sometimes consolidation even with air bronchograms within the consolidation, as you can see here. You can also have late stage ILD manifestations, like including bronchiectasis, like traction bronchiectasis, and also just bronchiectasis as such have been reported in these CT scans. So the lung manifestations can vary, and we don't clearly know what is a predictor of a particular kind of a lung manifestation. But here we see a comparison between those who had moderate COVID lung manifestations versus severe or critical lung manifestations. Obviously, the numbers are small here in this particular study. 39 patients in the moderate group and 7 patients in the severe or critical group. What was seen was that out of these patients who had ICU admissions and no ICU admissions, again, a bigger study for 103 patients, looking exactly at the same kind of data. Is there a difference between those who have severe and those who have less severe COVID manifestations? You can see that compared to those who have no ICU admissions, those who have ICU admissions tended to have much more. 43% of those patients had ground glass opacities, and 36% had parenchymal bands compared to only 16% or 22% respectively. So clearly, the more severe the lung disease during COVID, the more likely you are to have post-COVID lung fibrosis and these changes within the CT scan. Now, what may be causing this? We have heard several hypotheses of how the lung manifestations may be starting. This is an example which I took from the original SARS-CoV article, and this used to be a figure that I used very commonly in the early part of the pandemic, because at that time, the only thing that we knew early on was the role of ACE2 receptors, and the same with the original SARS-CoV infection, SARS-CoV-1. It uses the same receptors, and you can see all these virus particles merging around the membrane of the cell, trying to get in with the help of the ACE2 receptor, and they infest the cell. And over a period of time, perhaps what is happening is extensive damage that is caused by this coronavirus getting in through these ACE2 receptors. And perhaps the lung is trying to heal. And in that process, maybe a fibrotic process starts. The other possible mechanism is that this coronavirus, as it enters the cell through these receptors, maybe it is setting off an immune response. And the immune response could be because the virus particle may be presented, and this particular MHC peptide complex may be triggering a T helper cell response that ultimately leads to antibody production as well as cytotoxic T cell activity, which leads to destruction of the cells, and the T helper cell itself can produce a lot of cytokines, leading to a cytokine storm. Maybe it's immune mediated. It's not just a repair process. Now, these things are, I don't think have been sorted out yet. In addition to the immune process, the role of TGF-beta always comes up when there is fibrosis involved. For example, and TGF-beta also comes up when there is increased bone formation involved. And that's one common cytokine that has been studied, for example, in systemic sclerosis skin manifestations, because there's a lot of fibrosis there. Similarly, in idiopathic pulmonary fibrosis, TGF-beta has been studied. And you can see that TGF-beta is considered to be one of the prime drivers of fibroblast and myofibroblast formation within the lung. And perhaps along with this cytokine storm that you're seeing here, maybe you're having a lot of TGF-beta that is driving these fibroblasts. That could be one mechanism. You can see here that TGF-beta has varied manifestations. Apart from the fibroblast proliferation, you can also have increased matrix proteins, which again adds to that, adds to the probably the symptoms that you see in patients with lung involvement. It can have significant effects on, you see that the angiotensin 2 can drive TGF-beta production, and we know that via the ACE2 receptors, coronavirus has an impact on the angiotensin 2 system, which I will come to also in a little bit. And here is the mechanism by which perhaps there is increased angiotensin 2 receptor 1 activation. SARS-CoV-2, as it uses the ACE2 receptors, perhaps there is consumption and downregulation of ACE2 receptors, or the ACE2 receptors can be trimmed away used by ADAM17. When there is less ACE2 receptor on the surface, there can be an imbalance in the angiotensin 1, angiotensin 2, and subsequent reduction into angiotensin, either a nonapeptide or a hexapeptide here, the 7 amino acid peptide here, which acts through the MAS receptor and in fact prevents fibrosis from happening. When the ACE2 receptors are downregulated or are less in number, this conversion from angiotensin 2 to the better, or so to say, the safer angiotensin downstream product doesn't happen, and you have an excess of angiotensin 2, and perhaps through the AT1 receptor, there is increased fibrosis. So we've talked about possible, damage to the cells and healing with fibrotic activity. We've talked about the various role of cytokines. Now we're talking about possible renin-angiotensin system and fibrosis as a result of that. So overall, if you see that there are a multitude of mechanisms that have really been, put forward as hypothesis, and what seems to be driving most of the critical symptoms is a cytokine. Whether this is also the reason for the post-COVID lung manifestations, we really don't know that part yet. So what we have been doing in the lab is we're very interested in the lung manifestations, and early on itself, because of the similarity between the CT findings in COVID lung with some of the lung manifestations that we see with anti-MDF5 antibodies, which of course I see a number of patients with anti-MDF5 related lung involvement because of their association with myositis and severe inflammatory lung involvement. So we got interested in this area, and what we found, we tried to look at what could be driving this fibrotic process, and we took a chance and we decided to investigate. I can't really reveal the molecule here because we have not published this yet. So we decided to study a particular molecule and look at the lung of COVID patients, and this is the COVID lung with staining for this particular molecule, and this is a comparator COPD lung. And you can see the huge difference where the molecule is excessively present in COVID lung. And we were quite surprised to see that it was such a high amount in COVID lung. So we've gone on to do multiple studies to sort of establish the role of this molecule in COVID by looking at the genetic mutations, looking at the serum levels of this molecule in COVID patients versus control patients. Currently, we're analyzing the correlation between the severity of COVID and this particular molecule. I'll show you one more data here. In addition, what we did is to prove the point, we took that molecule and developed a plasmid for this molecule so that you can overexpress this molecule. We injected a control plasmid into a mouse model. We injected this particular plasmid with this molecule into another mouse, the same mouse model, and you can see that over a period of time, the mouse, multiple mice were involved. So the mice that were injected with overexpression of this particular molecule had significant fibrosis in the lung, sort of proving the point one more time that this is causal. It is not just an anecdotal finding that you see there. It can actually cause fibrosis. So hopefully we can publish this data soon, and you'll be able to read about this more. So lung is really just only one of the varied manifestations that you can see in post-COVID. Over the next 2 to 3 minutes, I will try to go through multiple slides. The most common manifestation of post-COVID syndrome, of course, is fatigue, joint pains, and chest pain. Fatigue being really significant for a lot of these patients. It looks like the post-COVID, as I mentioned before, seems to be much more common in those who had severe manifestations earlier on. And this is from the WHO website, where they have been trying to track post-COVID and lingering symptoms of COVID-19. You can see some of the manifestations. As I mentioned, fatigue seems to be the one that remains. They have it during the illness, and it remains after. And you can see that most of the, for example, the chest pain seems to be there. Those who had around 30% had chest pain before, and more than 20% seems to have chest pain even after they recover. So you can see the kind of distribution here. What clearly goes away is the fever and chills, because they are free of the acute COVID infection. But a lot of the other symptoms seem to stay, and loss of smell also seems to stick on for quite a bit of time. And the heart, the brain and nervous system, mental health issues, musculoskeletal issues, all have been reported in these patients. There is a study going on with the help of MRC UK and the University of Leicester, where 10,000 patients who have been hospitalized and are being followed up to see what the post-COVID manifestations can be. Hopefully we'll hear from I've not seen any definitive reports from this study. You can also have metabolism related changes, and just quickly, for one example would be, for example, islet damage and decreased insulin release has been reported in patients after COVID infection. So could post-COVID be more of a metabolic issue? Can there be issues related to metabolism and perhaps fat related changes, fat-related metabolism changes? The neurological manifestations, as I mentioned, apart from just mental health issues that have been reported, like significant depression that has happened post-COVID, there are cognitive issues that have been reported post-COVID, and whether it is because of hypoxia that was sustained at the time of acute COVID, or is it related to other mechanisms, we don't really know. We've heard of stroke, but also there is a possibility of GBS. Of course, macrophage activation can lead to CNS manifestations. Perhaps the medications could be causing these manifestations. Here is an example of 58 patients admitted to the ICU with ARDS, and all 58 patients were studied for neurological features. And you can see here that around 65% of individuals had confusion using the CAM, confusion assessment method. 70% had agitation. Long track signs were interestingly very frequent, with around 70% of individuals with long track sign, and this so-called dysexecutive syndrome. And you can see what are involved here, especially the difficulty to follow commands was present in around 36% of individuals. And if you look at the CSF, almost all patients, like 100% of patients, were negative for the actual virus PCR. So it doesn't appear to be directly linked to the virus, perhaps because of the oligoclonal bands seen here. Maybe my time is up. I just timed it. So I will just wind up here. You can see that there is significant leptomeningeal enhancement, which you can see with MRI. You can also see significant perfusion abnormalities, predominantly in the frontotemporal area. Even strokes are possible, and these could be minor strokes. And I'll give you just maybe one mechanism by which these strokes are happening. So one of the mechanisms is perhaps, again, as I mentioned, the renin-angiotensin system, where there is a prothrombotic effect through the AT1 receptor. But NETosis is something which we should consider. And NETosis is the process whereby neutrophils extrude out material that causes, that tries to engulf For example, infections, it also can be prothrombotic in stages. And this is an example of how netosis happens. You can see the neutrophils, they're extruding out a lot of material outside the neutrophils as a result of activation. And if you look at netosis in COVID patients, you see there is significant increase in cell-free DNA, myeloperoxidase DNA, and as well as citylated histone, which are markers of netosis, significantly increasing in COVID situation. And the netosis has been found to increase thrombotic manifestations. And one last point, the netosis seems to be linked to antiphospholipid antibodies, and this is quite a large study from Science Translational Medicine. And now this will be my last slide. Antiphospholipid antibodies are increased, and those who have these antiphospholipid antibodies seem to have increased netosis. If you take these antibodies out and inject it into mice, they develop thrombosis. So multiple mechanisms by which these thrombotic events are happening. And I will stop there in the interest of time.